Hey, hello everyone. Good morning, good afternoon, good evening, where in this world you are. My name is Jose Flores. I'm a urologist attending at Memorial Sloan Kettering Cancer Center. And today on behalf of the Sexual Medicine Society of North America, it is my pleasure to present this wonderful webinar about testosterone and cardiovascular disease. With us, we have Dr. Kara, who is director of the program in Houston, and our president of the society, the Sexual Medicine Society of North America. And we have Dr. John Mohawk, who is the director of the Reproductive Medicine Memorial Sloan Kettering Cancer Center. And also we have Dr. Dasmalchi, who is going to present the society, and Dr. Nasir.
Thank you so much. I'm Neda Dasmalchi. I'm a cardiology fellow at Temple University Hospital in Philadelphia, Pennsylvania, and I'm a member of the American Society for Preventive Cardiology. And I'm the honor to introduce Karam Nasser, who is the Chief of Cardiovascular Disease Prevention and Wellness, as well as serves as the co-director for Center for Outcomes Research at Houston Methodist. His clinical interest lies in the role of precision medicine and novel imaging tools for cardiovascular disease risk assessment and tailored management to prevent risk of heart disease. So we're going to start this panel discussion very soon. And before we start, I just want to let the audience know that they are more than welcome to ask any questions, but the best modality to go about this is to ask questions in the chat. And if you have questions for specific panelists, please address that panelist, and we'll be sure to address all questions as much as we can at the end of the discussion.
I think, Dr. Nasir, you're on mute.
Again, thank you so much, Dr. Dasmalchi, for the introduction. Of course, without further ado, trying to decipher the relationship between testosterone, replacement therapy, and cardiovascular disease. But as I was thinking about putting the slides, I think that we just need to think a little bit more on, I feel in the life of every man, I guess, lucky enough to live beyond his youth. And I think I'm in that stage. There comes the ultimate betrayal. Not a betrayal by a false friend or close confidant, but because such backstabbing pales beyond the inevitable hour that we are all facing, to borrow from the poet Thomas Gray, when the body starts betraying itself. So just a little background on testosterone. It's primarily a male sex hormone secreted by the testes, transported in the blood by the carrier protein sex hormone globulin. And if you look at the levels in men at approximately, that peaks at age 30, after which levels steadily decline at a rate of 1 to 2% annually. Now, hypogonadism or testosterone deficiency affects almost 30% of men age 40 to 79, and its prevalence is associated with aging. However, there are special high-risk groups for testosterone deficiencies: men with type 2 diabetes, obesity, metabolic syndrome, heart failure, pulmonary disorder, HIV. And when you look at almost 1 in 4 men greater than 64 of age will have low T levels. So this is kind of where it's really hard to ignore the growing burden. It's almost every 1 in 4 elderly men that we see in our clinic. But the question is, why worry about testosterone? Of course, apart from cosmetics and appearances, testosterone deficiency is a well-established medical condition that often associated with pronounced disturbances in quality of life, detrimental effect on multiple organ systems, and symptoms like decreased libido, erectile dysfunction, decreased energy, depressed mood, irritability, and decreased sense of well-being. But what about cardiovascular disease? Now, as far as cardiovascular disease is concerned, there is now undeniable association with unfavorable cardiovascular health. First, low testosterone level is strongly associated with an adverse metabolic risk profile, including insulin resistance, obesity, diabetes, positively correlated with the good cholesterol, negatively with low LDL, the bad cholesterol, and also inflammatory condition. And hence, clearly there is an understanding and a view that it may strongly relate to increased risk of cardiovascular disease. In fact, if you look at the accumulated evidence, multiple meta-analysis, there is an overall and increased CV mortality related to testosterone level. For example, Ridge et al. Found that higher testosterone levels are associated with decreased risk of cardiovascular events in men more than 70 with a hazard ratio 0.84, but not in younger men. In another large meta-analysis by Aruja that included 18 studies, more than 22,000 subjects overall, and cardiovascular mortality was related to the T levels. And although there is considerable heterogeneity in the studies, still clearly the association with low T and overall mortality, and especially with the cardiovascular mortality, is much more stronger. However, it's unclear if this is a causal association or due to low T being a biomarker of poor health. Now that we know that low T is associated with poor cardiovascular health, possible, now we also know that testosterone replacement definitely improves a lot of the things that may be related to heart disease, like type 2 diabetes, metabolic syndrome, waist circumference, fat mass, lean muscle mass. So one may be inclined to think that, well, there is a good chance that the testosterone replacement therapy will likely improve cardiovascular outcomes. However, it's not as simple. I do remember as a fellow way back in 2000, actually as a resident in 2009, the first insight of this issue was brought in by this famous study, Testosterone in Older Men with Mobility TOMS, which was a placebo-controlled trial designed to determine the effect of testosterone replacement on lower extremity strength and physical function in older men. Clearly remember in December 2009, there was a release from NIA and from the Data Safety Monitoring Board suggesting increased risk of cardiovascular disease. And the data was published eventually 6 months later that suggested increased risk of cardiovascular disease with testosterone. Now, but many issues, if you look at from this study, it was not planned for cardiovascular primary or secondary outcomes. Structured evaluation of cardiovascular events were not performed, a factor that might have influenced the ascertainment of events. Now, the next 2 years were slightly quiet, but in 2013 and 14 was really a busy year for testosterone, and we'll break down the science of these trials later, but one was published in November 2013, the other in January 2014, I guess, and the whole idea was significant suggestion of increased CV risk with testosterone replacement therapy, made a lot of headlines in popular media. In fact, 2 days after the second study was published on January 31st, FDA came out with the caution. I clearly remember that I felt that the FDA caution of increased cardiovascular disease was not based on good evidence and made in a haste. And why do I say that? Because if you look at the first study, clearly, again, a retrospective study of more than 8,700 VA men who underwent angiogram, who also had their testosterone level checked, but they excluded individuals who were previously treated or those prescribed testosterone replacement after an MI. And when they looked at the cardiovascular outcomes, it seemed there was a 30% increased risk among individuals who were started on testosterone therapy at 3 years. Now, I can tell you this paper stirred significant discussion. Some investigators pointed out that when they look at the raw data before various statistical adjustment, actually, and better outcomes were favored with testosterone. And in fact, since then, the investigators have printed many corrections, yet many investigators in the past have called retraction of this paper, and the debate still continues. And the second study was a retrospective study of nearly 60,000 individuals, claim-based data. It was the first trial using billing codes and prescription information, and the diagnostic indications for prescribing the T levels were not reported. There was no data on pre or post-treatment T levels. There was no control group. All they showed that Pre-prescription, the rates were slightly lower. Post-prescription, the rate were higher. As a cardiologist, when I look at the MI rates for this population, actually it's lower than 1/3 that what I would have expected for this population. Clearly, following these studies, the FDA continued to give mixed messages. In September 2014, a much-awaited FDA advisory committee thankfully found out that there is insufficient evidence to confirm an association with cardiovascular events and testosterone, as we have discussed so far. However, a few months later, in March 2015, the FDA issued a communication cautioning the use of testosterone not to be approved for men with age-related testosterone level, which is the most common thing, and should only be prescribed to men with low testosterone level caused by certain medical condition after assessing the risk and benefit balance due to possible cardiovascular disease. Now, as these controversies were brewing, national cohort of investigators have been planning more detailed interventions, a series of intervention where they took almost about 800 men, more than 65, treated them to a level of 50 to 800 nanogram per deciliter, double-blinded trial. The great thing was it was a coordinated set of clinical trials. Each trial was designed to test the effect on a known clinical condition, and the benefit was recruitment, screening, treating, monitoring, and the governance all facilitated a much coherent collection of the data. So what did they find? Of course, as expected, significant improvement in sexual function by questionnaire, physical activity in 6-minute test, slight improvement in energy level, although the total vitality was equivocal, increase in the bone marrow density. Those who were anemic saw significant improvement in the hemoglobin, no changes in cognitive function. So all good so far, but what about the cardiovascular disease still remained the big question mark out here. Now, leveraging this data, some of our colleagues, Matt Budoff at UCLA, incorporated another study where they said, well, although we may not have a full outcome study, but we can truly look at some of the surrogate marker, the coronary atherosclerotic plaque. So here, this is an example what you see on a CT angiogram, types of differential plaques, the non-calcified, the mixed plaques, and the most calcified plaque. And in a smaller subset of nearly 170 men out of the 800, what they found that with placebo as treatment compared to placebo, there was a slight indication of total increase in the total plaque burden during this 12-month of therapy, mostly around the non-calcified plaque. Of course, no major adverse cardiovascular events were seen, and that definitely the answer still remained unclear, still considering that this was a surrogate outcomes. Of course, we will talk about this. You need a definitive cardiovascular trial, and Dr. Kara will speak more about it. Thankfully, we have the findings came in the last week. But, you know, as a cardiovascular prevention program, what we have done is that we continue to work with our men's health clinic. Low testosterone is still considered a flag for higher risk. And irrespective, we think that this individual men should have tailored cardiometabolic management. Their risks should be assessed. For example, if they are already with an established cardiovascular disease, they should be treated as intensely. Among those who have not yet presented with cardiovascular disease, we definitely focus more on looking for underlying atherosclerotic burden, the most common test being the coronary artery calcium testing, which is a non-contrast gated CT scan of the coronary arteries, and helps us identify those with the highest burden of atherosclerosis at risk. And of course, tailored cardiometabolic therapy based on our guru, Dr. Roger Blumenthal, the ABCDE, trying to ensure that controlling their blood pressure, lipid lowering therapy, cigarette smoking, diet and weight, diabetes, and exercise. So This is kind of where we are. I think so. The evidence is still, the verdict is still out there, but irrespective, as a preventive cardiologist, my message to everyone with the low testosterone is lose some weight, quit smoking, move around and eat the carrot. And if we do all of that, I think so there is going to be a significant reduction in the risk, if there is any still associated with low testosterone. So thank you so much for the opportunity to present.
Thank you so much, Dr. Nasir. Wonderful presentation. So now we have our next presenter. He's an expert around the world, Dr. Kera, who is a professor of urology at Baylor College of Medicine in Houston, Texas. And currently, like I said before, he's our president of the Sexual Medicine Society of North America. He has been involved, very active with all the testosterone trials, remaining one of the TRAVERSE trial that he's going to show us some data today. So Dr. Kera, the webinar is yours.
Thank you so much, Jose, and thank you so much for the invitation to discuss testosterone and cardiovascular disease and the TRAVERSE trial. I just want to spend one moment thanking once again the American Society of Preventive Cardiology. This is such an important topic to both societies. I'm really glad to see both of us coming together in this collaborative effort. So just first, my disclosures. I do consult for companies that do make testosterone products. And for the past 6 years, I have been on the TRAVERSE trial steering committee. So before I talk about the TRAVERSE trial, I really want to set the stage. And Dr. Nasser did a great job in setting the stage, but I want to just share some further information. Up till 2010, the majority of the studies demonstrated that testosterone did not increase cardiovascular risk. In fact, the majority of the studies up to 2010 demonstrated that men with low testosterone had an increased cardiovascular risk, and that giving testosterone may have some beneficial effects on cardiac function. But it wasn't until 2010 with the TOM study, and then subsequent studies in 2013 and 2014, which demonstrated that there may be some increased risk with testosterone and cardiovascular disease. These studies, majority were retrospective in nature, but they did give some concern, particularly to the FDA. So during this time, this was about 2014, there was a lot of concern amongst many groups and organizations, and including the Public Citizens Group, that wanted to put a black box warning on testosterone products, stating that there may be an increase in cardiovascular risk. So it wasn't until September 17th, and this was 2014, when the FDA convened. And during that meeting, two main conclusions were made. One, it was felt that there was abuse of testosterone, and it was true that many men who had not had a testosterone level drawn were using testosterone up to 28%. Roughly 21% of men who started testosterone did not have a follow-up testosterone level. So it's of concern. And at that point, they restricted the indication for use, meaning that it is only on label if a patient has a true medical condition, such as pituitary tumor, testicular tumor. So reality was that 85% of patients who were treated with idiopathic causes were considered off-label. But the second thing that they decided to do was change the warning and precaution section in 2015. It's important you realize that what they put in there was that the long-term clinical safety trials have not been conducted to assess the cardiovascular outcomes of testosterone replacement therapy in men. To date, epidemiologic studies and randomized controlled trials have been inconclusive for determining the major for MACE, non-fatal MI, non-fatal stroke, and cardiovascular death. And so they wanted to put at the bottom, patients should be informed of this possible risk when deciding whether to use or to continue to use androgel in this case. Just remember that the EMA, which is very similar to the FDA, which is in Europe, looked at this data and declined to make any changes to their warning. So this was the birth of the TRAVERSE trial. So in 2015, the TRAVERSE trial is a response to the FDA guidance. TRAVERSE stands for the Testosterone Replacement Therapy for Assessment of Long-Term Vascular Events and Efficacy Response in Hypogonadal Men. At that time in 2015, the FDA stated, we are also requiring manufacturers of approved testosterone products to conduct a well-designed clinical trial to more clearly address the question of whether an increased risk of heart attack or stroke exists among users of these products. And that is where the TRAVERSE trial started. As many of you know, the TRAVERSE trial was published this past Thursday after 6 years of initiating this trial. So again, this is where I'd like to set the stage. Several other things were occurring around 2015. One is that after this was released, FDA guidance came out, there was a precipitous decline in the use of testosterone products, as you can see, particularly in men with a history of cardiovascular disease, because they were concerned that if they took testosterone based on the recommendations of the FDA and the recent studies, that it may increase their risk for having a heart attack. But even those who did not have cardiovascular disease also saw a decline in the utilization of testosterone products. There was a lot of litigation at this time in 2015 to 2018. If you remember, the commercials at that time stated that if you had taken testosterone and if you had a heart attack, you were entitled to compensation. And many of these litigations, some are still going on today. We also had the guidelines that came out. Majority of these guidelines came out around 2018. We're very fortunate to have Dr. Mulhall with us this evening, who is the chair of the testosterone AUA guidelines. But endocrine guidelines, the European guidelines, the British guidelines, all were coming out at this time, and they were a little bit different. They did not suggest that giving testosterone increased cardiovascular risk. Some of them said that it was inconclusive, but the majority did agree that men with lower testosterone levels did have an increased cardiovascular risk. So again, still somewhat inconclusive at that time. So let's talk about the TRAVERSE trial. This was a randomized, double-blinded, placebo-controlled trial, men between the ages of 45 and 80 years old. Now, the key thing you want to remember about the TRAVERSE trial is that these patients had cardiovascular risk. They either had pre-existing cardiovascular disease or they had increased risk of cardiovascular disease. And I'll discuss that shortly. So these are patients that had increased risk of cardiovascular disease. They had to have 2 levels below 300 nanogram per deciliter between the hours of 5 a.m. and 11 a.m. 6,000 patients randomized to either testosterone gel or placebo with up to a 5-year follow-up. This is what I was referring to earlier. If you look at the top, these patients either had pre-existing cardiovascular disease, meaning they had coronary artery disease, they had cerebral vascular disease, or they had peripheral arterial disease, or they could have risk factors for cardiovascular disease, and they had to have 3 of them, either hypertension, dyslipidemia, a smoker, stage 3 chronic kidney disease, elevated C-reactive protein, diabetes, poor calcium, coronary calcium score, or over the age of 65. So the study was designed where it was a 1-to-1 placebo versus androgel, 1.62. During the first year, there were 5 points in which we checked the blood, 2 weeks, 4 weeks, 12 weeks, 26 weeks. The goal was to put the testosterone level between 350 and 750. If someone had a testosterone level above 750 or hematocrit ever went above 54, they were then excluded from the study. They weren't adjusted and put back in. They were excluded from the study. And then the sham as well. There were titrations that were done in the placebo arm just to simulate those that were also getting testosterone. So what was the primary endpoint? The primary endpoint was MACE, right? So it's the time from randomization to first occurrence of any component of MACE for non-fatal MI, non-fatal stroke, or death to CV causes. Statistically, we had to have at least 256 adjudicated major adverse cardiovascular events to reach our endpoint. We had more than that, but the study was to continue till we at least had 256 adjudicated major adverse cardiovascular events. Secondary endpoints were just cardiovascular safety. So not only the incidence of MACE or cardiovascular procedures, but looking at cardiac percutaneous, coronary intervention, and CABG as well. And then very important, and one of the big secondary endpoints was prostate cancer. Not only the incidence of prostate cancer, but the incidence of high-grade prostate cancer, defined as Gleason 4+3 or higher. There were many other secondary endpoints. The other secondary endpoints were sexual function, depression, bone fracture, diabetes, and anemia. This data was presented at the ENDO meeting this past Thursday, and they did give the results of some of these trials. I just want to mention they did describe the results of the prostate cancer trial, demonstrating that there was no increased risk of prostate cancer between the two groups, and there was no increased risk of lower urinary tract symptoms between the two groups. Dr. Basine also presented the sexual function data as well, demonstrating that there was an increase in sexual activity and libido in those men on testosterone compared to placebo. What were the tertiary endpoints? Cardiovascular safety again, but a little bit different. All-cause mortality, hospitalization or urgent visits with heart failure, venous thromboembolic events, including DVT, PE, and VTE, or peripheral arterial revascularization. And then again, prostate safety, including who had a prostate biopsy, acute urinary retention, worsening of LUTs. Any invasive procedure like a TURP was also documented as a tertiary endpoint for prostate safety. So here's just a study timeline. The first patient was actually enrolled almost 5 years ago, May 23rd, 2018. In 2019, it was noted that there was not enough MACE events. So the steering committee decided to restrict the number of patients who had cardiac risk factors and just enroll patients with pre-existing cardiovascular disease. The end of the study began in May 31st, 2020, and the last patient end of study visit was January 19th, 2023, which was this year. So the follow-up, so we started out with a lot of patients, 5,204 patients were randomized, 2,600 with testosterone, a little 2,600 with placebo, but we had many patients that discontinued the drug. Roughly 60% of patients discontinued the drug. So the average time for which patients took the drug was roughly 22 months. We also had some patients withdraw from the study, but the average time for the study was 33 months for the study time. So let's look at the data. So almost 50% of the patients were above the age of 65, roughly. And it's interesting, if you look at the testosterone group and the placebo group, in all the charts and tables I'll show you today, they're relatively the same on both. But they were typically obese. The body mass index was roughly 35 in both groups. The starting testosterone was roughly 220 nanogram per deciliter in both groups. PSA less than 1 in both groups. Hematocrit looked good at 42 within both groups. So then if you look at cardiovascular risk, you look at between the two groups, it's relatively the same. Roughly 54% of patients had pre-existing cardiovascular disease and 45% of patients had increased cardiovascular risk. Roughly 44% of patients had coronary artery disease, 11% had cerebral vascular disease, and we had about 70% of patients were diabetic, 93% had hypertension, and 90% of patients had hyperlipidemia. The majority of the patients were on a statin or a lipid-lowering agent. Therefore, it's not surprising that the LDL cholesterol was within the normal range. Majority of patients, 60% roughly, were on an aspirin as well. If you look at the testosterone levels, there was a significant increase in testosterone levels, roughly 148 nanogram per deciliter in those patients taking testosterone versus roughly 14 nanogram per deciliter in the placebo arm. But the key point was that if you carried it out all the way, there was no significant difference in cardiovascular events, particularly death, CV death, non-fatal MI, or stroke. Look a little closer at this. The rate was roughly 7% for the primary endpoint in those patients taking testosterone and roughly 7.3% in those patients taking placebo. Even in the secondary safety endpoints, roughly the same, 10% in both groups. And again, in terms of death due to cardiovascular cause, non-fatal myocardial infarction, non-fatal stroke, and coronary revascularization, all were relatively the same between both groups. What I did think was interesting, if you look at the tertiary cardiovascular safety endpoints, although it was not statistically significant, there was a slightly higher increase in pulmonary embolism. It's 0.9% versus 0.5% in the placebo arm. But again, this was not statistically significant. And if you look closely at the investigator-reported adverse events, there were some surprises here. And the three surprises were that there was a statistically significant increase in non-fatal arrhythmias. There was a statistically significant increase in patients who had atrial fibrillation, who took testosterone versus placebo, and there was a statistically significant increase in those patients who had acute kidney injury. So those are the three. Now, if you look at the absolute numbers, and I want to take a closer look at that, roughly 134 patients who took testosterone had non-fatal arrhythmias versus 87 patients. If you look at AFib, it's 91 patients versus 63 patients, and we're talking roughly out of 2,600 patients. And finally, we're looking at the patients who had acute kidney injury, roughly 60 patients versus 40 patients. So again, although statistically significant, the absolute numbers don't seem that different. So in conclusion, TRAVERSE is the largest randomized placebo-controlled trial in hypogonadism men to date among middle-aged or older men with hypogonadism who had a history of established cardiovascular disease, who are at high risk for incident of cardiovascular events. TRT for a mean duration of 22 months did not increase the risk of major cardiovascular events. Thank you for your attention. I think we're now open for discussion.
Okay, so thank you so much, Dr. Kara. Wonderful presentation. So now we're gonna open for panel discussion. So Dr. Kara, Dr. Nasir, and Dr. Yomoho is gonna be in the panel. Please, if you have any questions, you can send us the questions, like Dr. Dasmalchi told us with the Q&A box or just by the chat. So we're going to start with some questions that we have here. We're going to be alternating with Dr. Dasmalchi. So first I'm going to start. We have some really practical questions. The first one is for Dr. Nasir. Dr. Nasir, a man with unstable angina and low testosterone, low T, when is safe to start testosterone therapy?
Well, and now, again, based on the data, if you look at the TRAVERSE data that Dr. Kara presented, clearly what it's suggesting that even if you have established cardiovascular disease, and a take-home message for me and for our patients is, as long as you're intensely treated, as you can clearly see, majority of these patients were on a statin, their LDLs were in a much controlled range than what you'd expect the other population. Clearly, we do not see any detrimental cardiovascular effects. So from my perspective, for the patients now, I have enough data to reassure them. And in the era that we didn't even have the data, my take home was, let's intensely treat all your cardiovascular risk factors. And maybe that's the message. Once you're intensely managing all your cardiovascular risk, there is not any detrimental effect that you're going to have with testosterone. Now, the question is, in pre-era, also, we had significant evidence, as Dr. Kara pointed out from epidemiological and other studies, that there is no signal, there is no benefit, but I don't see any detrimental effect. As long as it can improve your quality of life and your symptoms, absolutely, we should go ahead with that.
Thank you, Dr. Nasir. Dr. Dalmachi.
Yeah, thank you so much for both of those great presentations. So one of the questions I have is in regards to the study. It can go for both Dr. Kara or Dr. Nasir. Based on the results of the study, there was some evidence that there was an increased risk of atrial fibrillation and pulmonary embolism in patients who were treated with testosterone therapy. How would you, based off these outcomes, how would you educate patients on starting at testosterone therapy?
Go ahead, please.
No, please go ahead, please.
I think that the atrial fibrillation was a load of a surprise. I did not expect to see AFib go up with testosterone therapy, and we typically don't see that clinically. So, but again, the absolute number was not so significant, but it was statistically significant. I think, if you read the paper that came out, they mention this. They say, look, although there was a slight increased risk in pulmonary embolism, the paper mentions caution in men with a history of PE. So not the patient that's naive and doesn't have no history of PE or DVT, but in a patient who has history of PE, you may want to use some caution in prescribing the medication. That's very similar to the European guidelines as well, is that they state, caution with patients with a history of DVT. I think that's a reasonable statement, but the data on a patient who does not have a history of PE or DVT is not convincing that it may increase the risk.
Fantastic, thank you.
So I echo what Dr. Khera just said. From my perspective, it's definitely a curveball. We need some more investigation in trying to understand the association with atrial fibrillation and some of the very limited, I would say, thromboembolic phenomena. But, as a part of the shared decision making, if you're not taking testosterone, the risk of having an AFib, and again, how well documented, because this is physician reported, not adjudicated, is 1 in 40. And if you're taking testosterone, and it's close to 1 in 30. So, when you put those numbers in versus the benefit you're going to get with your physical activity, libido, sexual drive, anemia, bone, I think so. We have to look into totality. We just can't really just focus on that one limited side effect. And it's always the benefits versus the risk. In my view, overall, the data is very reassuring.
Fantastic. Thank you both so much.
Perfect. We have here 2 questions from Dr. Rahim. Thank you so much. One for Dr. Nasir and one for Dr. Khera. So Dr. Nasir, in men with prior cardiovascular events, do you recommend starting testosterone therapy after 6 months interval? And Dr. Khera, can you comment on fracture rates in the TRAVERSE trial? Dr. Nasir, I think you should be the first.
Honestly, the data is uncertain. I have no idea whether there is a time interval where you start, but somebody had an acute MI and STEMI. In general practice, we're going to take the first 3-4 months and really trying to optimize their cardiovascular risk factors, their lipids, dual antiplatelet therapies, blood pressure control, diabetes management. And of course, in that conversation, I don't know in the list of the priorities where the testosterone replacement therapy would be. Now, if that comes in, I don't have any hesitancy in recommending not to start or to start. So I'm agnostic, but I think it's all right from our perspective. There is no indication from the timing of an acute event that whether we should be holding testosterone replacement therapy in that time frame.
You commented on the fracture data. So just remember the fracture data has not been published, but it was presented by Dr. Snyder at the endo meeting this past Thursday. And what was surprising from the fracture data was that those men who took testosterone had a higher fracture rate than those men in the placebo. So it was kind of opposite what we thought. And I thought about this. I mean, it's really hard. I can't give you a good explanation for why that is. My only thought was, and we see this in other trials as well, is that when men who do take testosterone do have increased vitality, they do have increased energy, they tend to do more, and they may be engaging in behaviors that may increase their risk for having a fracture. But that's the best I can give you at this point.
Excellent. Dr. Dalmachi, you can go with the next one.
You're muted.
I think you're mute.
I'm so sorry. So there's an anonymous attendee who asked, after radical prostatectomy, how long would you wait to give testosterone therapy?
So I would actually like to defer this to Dr. Mulhall. John, can you comment?
So maybe I could make a comment about who I am and what I do. I was the chairperson of the AUA guidelines published in 2018. The update of that will be published this year. I run the sexual and reproductive medicine program at Memorial Sloan Kettering, 1,600 new patients a year, 30% of which have low testosterone. So extensive experience in this space. Very importantly, I have no conflicts whatsoever in the testosterone space. We see about 600 new prostatectomy patients a year, so low T in that population is very common. We will wait for 12 weeks after a radical prostatectomy. We will check a PSA, and if that's undetectable and the patient has low to intermediate grade organ-confined cancer, then there is a fairly brief discussion about the role of testosterone therapy. When we start getting into patients who have unfavorable pathology or higher risk disease, then it becomes more complicated. But there is really no patient population with prostate cancer outside of those with metastatic disease that we would not consider testosterone therapy for. Going back to the 2014 data from the FDA, from the literature, I think, as Mo pointed out, there were significant concerns about that. And I actually wonder, and have wondered for the last several years, whether the label change has hurt many men, very much in the same way perhaps that the Women's Health Initiative did previous to that. So I think that we need to be much more cautious about the label and much more focused on the newer data, which is supportive. And the AUA guideline says this, that low T is a risk factor for major adverse cardiac events. So I'm a big proponent in the right patient, low T, symptoms or signs, to early morning T levels of treating patients, including those with prostate cancer, with T therapy for quality of life and possibly even longevity.
John, you bring up a really good point, and I think we're very fortunate to have the American Society of Preventive Cardiology on here, Dr. Desmalchi, Dr. Nasir, because you just mentioned that low testosterone increases the risk for cardiovascular events, and we feel pretty good about that. The question is, not only is it safe to give it, but do you believe, and we should just, does it decrease the risk of cardiovascular events? If I give someone testosterone, do you find it could be protective against future cardiovascular events? And there's been all kinds of data here and there about it. Some have argued, well, maybe if it decreases diabetes and it decreases obesity, and those are risk factors for cardiovascular disease, maybe indirectly. Some have argued maybe there's a direct effect. And I would really like to hear from Dr. Nasser, Dr. Damachi. What do you think about that thought?
I completely agree. So cardiovascular disease is one of the overall endpoint that you're looking when you're speaking with the person, right? And from my perspective, what at least the data suggests that once you intensely manage the appropriate cardiovascular risk, maybe the added value independently in reducing the cardiovascular risk may not be there on the short term. Maybe a longer term follow, we may see some benefit. But at the same time, we do see significant additional benefits, which are extremely meaningful and impacting the quality of life. So really the question, our patients are more concerned, they're not having testosterone replacement therapy specifically for reducing cardiovascular risk. We already have well-established, simpler agents, therapeutics to address that. Their question is, am I at risk? Is it safe to take? And at least now in 2023, based on the totality of the data, now I think we can very conclusively suggest that. So that's my approach and philosophy here.
Very helpful.
Excellent. This question, wow, first, thank you so much. We have so many excellent, good, really good questions. This is for the panel. This is the question is here, if now we need to consult patients who have atrial fibrillation, who already are on testosterone therapy based on the TRAVERSE trial data. So what is your opinion, Dr. Khera, about that? Now we need to counsel about that, atrial fibrillation and testosterone therapy?
Well, I think you can't ignore it. You have to acknowledge that it happened, right? I think you can talk about the absolute difference in percentages, which is slight. But I think that, at the end of the day, it is what it is. I can say that there was a slight increased risk in AFib in this trial. And it's something you should be aware of. But again, I don't think there's any way around it but saying that's what happened.
I'd love to ask Dr. Nasir a question about biological plausibility. What would be the mechanism by which testosterone therapy would induce atrial fibrillation?
And my answer is I have no idea. And I'm sure most of the folks out here, it's hard. So clearly, of course, we know the relationship with erythrocytosis, which the thromboembolic phenomena can still make a sense. But in all honesty, I'm scratching my head since the results came back. But hopefully talking to some of our EP guys and doing a further investigation. But again, the question really is, how valid and how accurate was the atrial fibrillation reports? Because again, as we see similar issues in the original TOM study, where those were not the adjudicated events, and it took us almost 13 years to really come over what we reported. I think so. If we wouldn't have done that, we might have not had the TRAVERSE trial. So this is where I'm not certain on what exactly is going on here, and even if it's valid.
I have a question for both of you as well. In our literature, we're always talking about this erythrocytosis. You got to be careful. You get an elevated erythrocytosis, you're more likely to have a heart attack. And the data seems like that really comes from the polycythemia vera data, like primary erythrocytosis, not necessarily secondary erythrocytosis where someone's in high altitudes or they take testosterone. And it seems like those would be different. Is there a hematocrit where you would say, I think this person's at an increased risk for having an MI? And do you counsel the patient and say, hey, your hematocrit is this, and I think you're more likely to have an MI? Does that happen in the cardiology world?
We don't deal with this, in all honesty, Dr. Kara, mostly. But if you look at the guidelines, and again, if you look at the Sexual Medicine Society of North America, there's always a suggestion that you should be evaluating hemoglobin and hematocrit every 3 to 6 months. The consensus, most of them, is this 3 to 4 months. When you look at the Endocrine Society clinical guidelines, the suggestion is hematocrit greater than 54. Either you discontinue or you do offer therapeutic phlebotomy. Experts in our institution tend to recommend around 50% or more. But again, whether erythrocytosis by itself has any direct mediation on the thromboembolic events, that also still remain unclear. Now, clearly, we have seen slight of that signal. I think so that's an opportunity for us, all the societies coming together to really say, what would be the suggestion? How often should we discontinue therapy, or should we start, I would say, phlebotomy even much earlier? And would that even make an impact? Definitely, that's a space that needs more attention.
Thank you so much, Dr. Nasir and Dr. Kera. That was exactly one of the questions in the list that we have, the hematocrit level. So I think, Dr. Dasmachi, we have one question from Charles German. Can you go with that?
Dr. German's asking for Dr. Kara, in the TRAVERSE trial, were there any subgroup analyses conducted stratifying by achieved testosterone level? He states that he's curious if the results may be different for participants that may have a higher testosterone level after treatment. What are your thoughts?
Yeah, I don't have that data today, and it wasn't presented at the meeting nor in the paper, but it's an interesting thought because there is data to suggest that different modalities of testosterone, particularly injectables, may have a higher risk, a CV risk. And that mechanism typically is erythrocytosis. So we know the rate of erythrocytosis with an injectable can be as high as 67%, with the gels down to 12%. So patients with higher levels tend to have higher erythrocytosis rates. There is some belief also that testosterone causes sodium retention, and higher levels will cause hypertension, which is a cardiovascular risk factor as well. So theoretically, higher levels could be at greater risk. And it's been shown, there's been studies showing the injectables may be a greater risk, but that wasn't done or presented at this point.
Perfect. Thank you so much, Dr. Kera. Here we have a question from Andres Gonzalez. I think this is for Dr. Nasir. Is any cardiovascular condition that we need to make sure before starting testosterone therapy?
Again, as consistent to what we have spoken earlier, so far at least, I haven't seen anything that would be a contraindication. Of course, now if you had significant thromboembolic events, now I'm just going to be a little cautious, or if you have thrombophilias, factor 7 Leiden, antiphospholipid antibody syndrome, some of these gene mutation, high factor 8, and I don't know whether we should be checking homocysteine levels. I have no idea. But again, apart from the ones who have significantly demonstrated thromboembolic phenomena, I don't see yet any significant area that we need to exert caution. My message is again very clear. If you have somebody with cardiovascular disease, treat them intensely for cardiovascular, control their blood pressure, lower their lipids, control their diabetes, help them with obesity, sleep apnea, exercise, and lifestyle. And if we do that, you have already reduced the cardiovascular risk significantly, that you can easily and safely pursue and continue with the testosterone replacement therapy.
Dr. Nasir, would you accept that men with extremely low testosterone levels, below 200, for example, are difficult to motivate to get to the gym? That perhaps the ability to control their sugar problems is more difficult, and perhaps T therapy should not be a secondary or tertiary approach, but a effective primary approach?
I know that's definitely a very challenging situation. In our practice, especially, I see all of these things go hand in hand, metabolic syndrome, especially obesity. Almost majority of men, irrespective of their age, with BMI more than 35, we routinely check for testosterone, have significantly lower testosterone. Sleep apnea. So when you start thinking about distangling this, it's a lot of lifestyle risk factors, but a lot of obesity. So what we are trying to do is a very comprehensive approach for these patients, especially those with morbid obesity who have low testosterone. We help them connect with the men's health. We assess them for sleep apnea. We start them on sleep apnea treatment. Now, thankfully, we have therapies with GLP-1 receptor agonists that help lose 20 to 30 pounds. Connect them with our dietitian and our lifestyle coaches. And I can tell you, Dr. Mohal, we have extreme success stories where a combination approach, including testosterone replacement therapy, help folks lose 30 to 40 pounds. And some have gone, almost about 20% of our patients in that group have even lost 60 to 70 pounds. So I think comprehensive approach will work, because that's the area I'm dealing with, not just the testosterone. Testosterone goes hand in hand, and I think it also helps with the weight loss and motivating them for their lifestyle interventions.
And Dr. Mohal, based on your experience in managing testosterone therapy, what is your advice to treat men with cardiovascular event or cardiovascular history and low testosterone?
You know, when we review that data, and remember the AUA guidelines is a systematic review with meta-analysis, looking at those patients with a prior history, the Endocrine Society guidelines and our guidelines, it's just an expert opinion. And this idea that you need to wait 3 to 6 months is an expert opinion. There's not a lot of data that suggests that or supports that. So if you accept the AUA guideline says that men with low T are at risk for MACE, and you have a patient who's, let's say, a month after coronary artery, let's say a myocardial infarction and revascularization, and we're withholding testosterone on those patients for another 6 months, is that jeopardizing that patient? Now, I don't know, there's no data, but I'm concerned that if a man has very low T levels and he's caused to wait for months after a cardiac event or coronary revascularization, that's a problem for that patient. So I think these are things I would love to see the Traverse group look at if possible.
But John, you'd mentioned that you're there's going to be a new guideline. There could be a new guideline coming out. What do you think the Traverse will have on the impact of the new guidelines, particularly in the time to wait? Do you think it'll impact?
Well, we've postponed the release of the guidelines edits, the update, while we wait to review the Traverse trials. So I think it'll have an impact for sure. I was very reassured with the Traverse data. I wasn't surprised with the Traverse data. But I think it'll take probably till the end of this calendar year before we have a real update from the AUA.
Mm-hmm.
So I think, please, Dr. Kira.
There's this interesting phenomenon that kind of occurred, in 2015, it came out that, there may be an increased risk for VTE and there may be increased risk for MACE. And the VTE story kind of quieted down and we kept on going with the MACE. And we just said, hey, there could be increase for MACE. And it just seems like now that the Traverse trial came out, we've kind of quieted the MACE, but we kind of re-woke up the VTE story just a little bit. Because, in the paper, it does say, in caution with patients who have a history of VTE. And so, I think it's an interesting thought because historically I was not, I was more concerned about the MACE until the results came out, to be honest with you.
The other thing that I'd like to remind the non-urologists on the call about is the link between testosterone and PSA. And if you don't have enough testosterone in your blood, you cannot make PSA. And there is a delay in diagnosis. In fact, men with low T are at higher risk for higher grade, higher stage prostate cancer. So Mo, again, another sub-analysis that the Traverse group want to look at men with T levels below 200 or 250. In fact, the first author on the most recent paper in this regard is Jose Flores. That clearly shows a link. That link is most pronounced in men with higher grade cancer, Gleason 8.
I think for the time we have opportunity to go with 2 more questions. Dr. Dalmachi, can you read the Dr. Rahim question? I think that is for Dr. Kira.
Yeah, of course. So for Dr. Kara, what's your opinion about the post-Traverse era? Do you think that the safety data, especially for cardiovascular disease risk, would increase androgel use versus other products, or will it increase the use of all testosterone therapy products?
Well, it's a class effect, right? So testosterone is not different whether it's a gel, injection, a pellet. It's the same drug. These are different vehicles to get into the body. So essentially, I think that it's a class effect, whether using one drug or the other doesn't matter. One could say, is there a difference between higher levels and lower levels, right? Because the average T level was 400, and you say, can I use this data on injectable data at 900? Is it the same thing? So that may be tough to do. But if you're using a nasal gel or an oral or and getting into the same range, I think that this is a class effect and you can use the same data.
And the last question is for Dr. Mojo. Dr. Angela Nakarato wants to know your opinion about cardiovascular risk for men with prostate cancer that are on ADT therapy. What is your opinion for those patients?
So androgen deprivation therapy is used as an adjunct for men who receive radiation therapy as primary therapy for prostate cancer, and of course in men with metastatic disease or advanced disease, and in some patients with high-risk features before radical prostatectomy. So the use of drugs like leuprolide, relugolix, abiraterone, and I think the literature is fairly clear on this. When you have no testosterone, when you have castrate-level testosterone, you're at significantly increased risk of cardiovascular events. Now, there's a big difference between agonadism, T levels below 50, and hypogonadism. So I think it's important to point that out. But yes, I think that low T, extremely low levels of T, are at risk. And the Wally Shores data showed that from the VA many years ago. So they're a patient population who get counseled by me about bone, sugar, heart issues.
Excellent. Wow, I'm impressed. So many good questions, but the time is now. This is for 1 hour webinar. So now Dr. Kara is going to give us the final words for this webinar. Dr. Kara.
This was a fantastic session. On behalf of the SMSNA, I really want to thank the American Society of Preventive Cardiology, Dr. Nasser, Dr. Dasmachi, Dr. Galati, everyone at your organization for this joint webinar. It's really an important topic for both our societies. It's really nice for both of us to come together on this. I just want to also thank Dr. Mulhall, Dr. Flores as well, and the SMSNA crew for really putting this together. So again, thank you all, and have a wonderful evening.
Thank you so much, all the attendees. Thank you so much, and have a wonderful night, okay?
Thank you.
Thank
Bye.
you.